Welcome to all my physician friends, family medicine physicians, emergency physicians. Welcome to the series of Beyond Prescription series where we do internist practice update. Today our topic is Finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. We will see what are the major updates regarding Finerenone right now. So as a class, we all know that Finerenone is a non-steroidal mineraloreceptor antagonist, which is a third generation drug. Higher MR selectivity and potency is seen, and it has got no progestogenic or androgenic effects, and it is structurally distinct from the other two, that is a spironolactone and eplerenone. It was discovered in 2021 for FDA approval by Bayer for diabetic kidney disease, and FDA later approved in July 2025 for use in heart failure with preserved ejection fraction or marginally reduced ejection fraction, that is an ejection fraction of more than 40%. And you have got the latest study that is coming out, which is the FIND-CKD, which is waiting for FDA filing in 2026, which approves its use in non-diabetic kidney disease. We have got so many Indian brands like Kerendia, Finerenone, and we have got generics, and the available doses are between 10 milligram and 20 milligram tablets. The mechanism of action is primarily, as we have seen, Finerenone blocks mineralocorticoid receptors, and it reduces inflammation and fibrosis. So by reducing inflammation, it reduces the renal fibrosis, glomerular hypertension, it reduces cardiac fibrosis and decreases the risk of heart failure, and there is cardiorenal protection beyond BP lowering action. And the key advantage is that higher MR selectivity than spironolactone, and the absence of progestogenic and androgenic off-target effects. And the tissue distribution is more towards kidney and heart and not to adrenal gland. So that is the major advantage of Finerenone. When to start? This is the most important thing that as physicians you should be aware. The lab criteria you have to check is eGFR, or the estimated GFR, should be more than or equal to 25 ml per minute per 1.73 meter square. And serum potassium should be less than 4.8 millimoles per liter. Urine albumin creatinine ratio should be more than or equal to 30 milligram per gram, and the urine albumin creatinine ratio should be more than 300 milligram if the eGFR is more than 60. And the patient should be on maximum tolerated ACEi or ARB. We will see what is the maximal dose later. And there is no concurrent steroidal MRA use, that is spironolactone or eplerenone. And the maximum doses I have listed, usually telmisartan more than 80 and olmesartan more than 40 and ramipril more than 10 is the usual ARBs and ACEs that we use. Do not start if potassium is more than 5 millimoles per liter, and if the eGFR is less than 25 ml per minute, and if there is child pug category C liver failure and use of strong CYP3A4 inhibitors like itraconazole, ritonavir, clarithromycin, ketoconazole, and there is concurrent use of steroidal MRA. The dosing strategy is again dependent on the eGFR. If the eGFR is between 25 to 60 ml per minute, you can start at 10 milligram, and after 4 weeks by monitoring you can up titrate to 20 milligram. If eGFR is more than 60 ml per minute, you can start directly at 20 milligram and you can maintain at 20 milligram once daily. If eGFR is less than 25 ml per minute, the drug is contraindicated. Always check potassium at the end of 4th week to make sure that it is below 4.8 millimoles per liter, then only up titrate from 10 milligram to 20 milligram. And the monitoring schedule I have already mentioned in the table. Okay. Indication, the most important indication, the first to be approved in 2021 was for type 2 diabetes with chronic kidney disease. That came in 2021, and it reduces the progression to CKD and to end-stage renal disease and cuts the risk of cardiovascular and heart failure hospitalization. Again in 2025, FDA approved it for use in heart failure with preserved ejection fraction or heart failure with marginally reduced ejection fraction, where the ejection fraction is more than or equal to 40%. Again, it reduces the cardiovascular death, total heart failure events, and the evidence comes from FINEARTS heart failure trial evidence. And finally, the latest thing awaited is the FIND-CKD phase 3 trial, which is awaiting FDA filing in 2026. As of now, June 2026, for non-diabetic kidney disease as well, which slowed eGFR decline to 0.7 ml per minute per year, and there was a 23% decrease in cardiovascular kidney outcomes, and it led to use of Finerenone in hypertensive nephropathy as well as in IgA and nephropathy. Safety profile, the most important thing that you have to monitor is the potassium level. You have to be concerned if the potassium is more than 5.5 millimole per liter, and stop the drug if potassium is more than 6 millimole per liter. Always ask the patient to restrict salt and potassium supplements. And the major advantages is the absence of gynecomastia, sexual dysfunction, but there is a moderate risk of potassium, but much better than the spironolactone, a higher MR selectivity, and there is a renal protection RCT evidence available for Finerenone, which makes it a drug of choice. Again, these are the major trials that favors the use of Finerenone: the FIDELIO-DKD study, the FIGARO-DKD study, and now the latest FIDELITY study that came in EHJ in 2022. And the heartbreaking news is the FIND-CKD trial, which studied about 1,500 patients with eGFR between 25 to 90 and urine albumin creatinine ratio of 200 to 3,500 milligram per gram. And the primary endpoint was 0.7 ml per minute per 1.73 meter square in single year, which showed a slowing of eGFR decline and a 23% decrease in risk. And this may lead to the approval of these drugs in non-diabetic and heart failure cases like hypertensive nephropathy and in IgA nephropathy. So very hopefully these things will come. And so in addition to the three previous drugs we are having, that is the ACE inhibitors, ARB inhibitors, the SGLT2 inhibitors, and even the GLP receptor agonist, we have got the fourth pillar, Finerenone, that can be used to reduce the progression of chronic kidney disease, whether it is diabetic disease or a non-diabetic disease like hypertensive nephropathy or an IgA nephropathy, and it has got cardiovascular protective effect as well. And these are the major evidences snapshot I have written. You can go through the table, and this is the summary of what we have discussed. A beautiful image, you can go through it, you can understand everything. And thank you once again for your patient listening. If you want a PDF document, you can click below. A PDF document of what we have discussed is available free of cost. Thank you.